I think that is always a challenging scenario. And I believe if we're having 10 medical oncologists sitting in the same room and we ask them the same question, you're going to get different answers. And um, in truth, there is no one right answer here. But I think we're seeing this increasingly often in our clinics because those patients they know that they have a much guarded prognosis compared to the ones that don't have the co-mutations. So they come to us for second and third opinions. And in literature, is about maybe 10 to 15% of patients that harbor this co-mutation. But because the co-mutation really reflects the biologic complexity rather than giving you a single clear answer on how to proceed, that is why we're getting this discrepancy. So for me, ESR1 plus PIK3CA tells me upfront that this is a tumor that established some form of endocrine resistance. So I'm generally thinking in terms of combination therapy rather than monotherapy. And from a biologic standpoint, ESR1 mutation makes an oral SERD as a backbone very appealing. You're dealing with ligand-independent ER signaling, so I think that is the right choice for that part of the equation. The PIK3CA mutation tells you that the PAM pathway is also actively contributing to resistance, but having both doesn't necessarily dictate that the PI3K inhibition is always the first or the only choice. It just means you need to address both axes at some point along the journey of treatment. So in practice, I let the clinical picture of the patient guide how I prioritize my choice. And in patients with a more aggressive disease, they have early progression on a CDK4/6 inhibitor, they have visceral involvement. I tend to favor the most, what is the right word here? The most deliverable, probably, and reliable combination. Deliverable in terms of tolerance. So while PI3K directed therapy is very biologically appealing, I think tolerability can be a real limitation. So in many cases, an oral SERD plus everolimus becomes a very practical option that patients can actually stay on long enough to derive benefit. Now, in contrast, if the disease is a bit more indolent or intermediate in tempo, that is where I would be more inclined to use a mutation matched approach like a PIK3CA or AKT inhibitor with a SERD. Because you have the time and the clinical stability to realize that targeted benefit um, could eventually give you the desired effect without a rush. Of course, we don't have the capability as of yet, but the choices now are either oral SERD based therapy versus fulvestrant and capivasertib. We don't have the chance of combining both based on FDA approval as of yet. So I try to make um, somehow a creates some sort of a flexible um, pattern in my mind. And I know we always try to tell our fellows and residents and discuss with each other that we should not do cross-trial comparison because I think the studies differ so much in many different ways. They differ in the population they tested, in the backbones, in the endpoints. Um, so I think we should focus definitely on the biologic rationale and how well tolerated those medicines are and the urgency of disease control. But having said that, let me contradict myself. And I have to look at the numbers, and I try not to focus on the specific numbers with decimal points, but I try to get an idea from the subgroup analyses. And I think we are very lucky to have a lot of subgroup analyses from major phase 3 trials. So we have the Emerald, we have Ember 3, we have Evera, and all of those give us subgroup analyses for the co-mutation patients. We even have real-world data for elacestrant, more than one set of data set that looked at that. On the other hand, we have trials like Capitello 291 that did report a ctDNA analysis for the co-mutated population. We have the BYLieve trial. And I remember like looking at all of those numbers The two trials that are focused on the PIK3CA or AKT inhibitors and all the other trials, oral SERD trials, when they used a monotherapy, you can see that the average duration of PFS is somewhere in the mid 5 months, maybe up to 6 months. When we look at the combinations, and the combinations here were provided by trials like Evera or EMBER-3, you can see that the median PFS for this co-mutated population was a bit higher. So we're talking about higher than 10 months, higher than 12 months, even with EMBER-3. So I think the bottom line here is the co-mutation pushes me towards combination therapy, but it doesn't lock me into a single pathway inhibitor. The choice between PI3K, AKT, or mTOR is really driven by how aggressive the disease is, and more than that, what I think the patient can realistically tolerate over time.